Welcome back to the deep dive. Today, we're tackling something, well, pretty common but often misunderstood. Bedwetting.
Yeah, and the official term, the latest standard calls it bedplassen, which is interesting in itself.
It is, and it kind of signals a shift, doesn't it? Away from maybe just seeing it as a childhood thing.
Exactly, because our sources, the NHG guidelines we're looking at, they make it clear this affects adolescents, even some adults. It's not just a little kid issue.
Right. So our mission today is to really dive into this latest clinical standard. We want to get to grips with the definition, the surprising causes, and maybe most importantly, the non-drug treatments that actually work.
Yeah, the stuff that has real evidence behind it.
So if you're prepping for a discussion, or maybe you know someone going through this should give you the essentials.
And look, if there's one big takeaway right at the start, it's this. This isn't primarily about medication.
Okay.
The best long-term fix is all about behavior, about training, addressing that brain-bladder connection. And it really starts from age 5.
So patience is key.
Absolutely. Pills. They're more like a temporary patch, not the actual solution.
Okay, so let's get the definition straight first. What exactly are we talking about when the guidelines mention clinical bedwetting?
We're focused specifically on what's called monosymptomatic enuresis nocturna.
Right.
Basically, involuntary peeing in bed at night.
Okay, simple enough. But is there a frequency threshold?
Yes, it needs to be happening at least twice a week for the last 3 months. Or, and this is important, it counts if it's causing significant distress, even if it's less frequent.
Distress to the child or the family?
Either, really.
Right.
And crucially, we only start thinking about intervention, diagnosis from age 5 upwards. Before that, it's generally considered normal variation.
And you mentioned monosymptomatic. That's key, isn't it?
Hugely important.
Yeah.
If the child also has issues during the day, like wetting accidents, needing to go constantly, real urgency that's different.
That points to maybe a broader bladder issue.
Yeah, exactly. That needs a whole separate workup. We're just talking about the nighttime only scenario here.
Got it. And within that nighttime scenario, there are 2 types, right? Primary and secondary.
Yeah. Primary is the kid who's basically never been consistently dry at night. It's often thought of as just a bit of a delay in maturation. Things haven't quite clicked yet.
Makes sense. And secondary.
That's when a child was dry at night for at least 6 months solid and then starts wetting the bed again.
Okay. And parents must worry then, thinking something new has gone wrong, like an illness.
They often do, yeah. But interestingly, the source material suggests, well, maybe not. Newer studies are finding the underlying mechanism, the biology of it, is often the same for both primary and secondary. It's still that brain-bladder connection issue.
So the treatment approach doesn't necessarily change drastically?
Usually not, no. The underlying problem is often remarkably similar.
Okay, that's interesting. Now, the bit that surprised me in the reading was how long this can go on. We think 10-year-olds, but you mentioned adults earlier.
Yeah, absolutely. The numbers drop off quite a bit after 18, obviously, but it doesn't vanish.
Really?
The sources cite about 0.5% prevalence in adults. So 18 to 64-year-olds.
0.5%. That's still quite a few people when you think about the whole population.
It is. And the data also shows it tends to hang around longer in males compared to females.
And thinking about that adult prevalence or even just adolescence, it really drives home that this isn't just about wet sheets, is it?
Oh, not at all. The guidelines really stress the psychological side. It affects the whole family.
The shame factor must be huge.
It is. Deeply felt shame. Think about a teenager, having to say no to sleepovers, school trips, camps.
Yeah, that's tough.
That constant fear really limits their social life, chips away at their self-esteem, creates this negative self-image. Dealing with that emotional burden is like step 1.
Right. Let's move on to causes then, and maybe start with the biggest myth parents often mention, according to the sources, the deep sleeper explanation.
Ah, yes, the classic, oh, he just sleeps like a log.
Is there any truth to it?
Honestly, very little. The guidelines are quite clear. How deeply someone sleeps isn't really the main issue.
So it's not about sleep depth.
No. Bedwetting happens across all sleep stages. The real problem, the key physiological factor, is the brain not getting the message, or rather not reacting properly to the full bladder signal. That arousal response is insufficient.
So it's a specific signal failure, not just being generally conked out?
Precisely. The brain hasn't made that crucial connection. Full bladder means wake up now. It's a learning or wiring delay.
Okay, that makes more sense. And that's what the training aims to fix, presumably.
Exactly. It's about establishing that conditioned response.
Now, what about genetics? The sources seemed very strong on this link.
Oh, it's huge. Probably the single strongest predictor. The family connection is really quite striking.
How striking.
Get this. If both parents wet the bed as kids, their child has a 77% chance of doing the same.
Wow, 77%. That's massive.
Isn't it? If just one parent did, it's still high, around 43%. If neither parent had issues, the chance drops way down to about 15%.
So genetics sets the stage, in a way. Does that mean behavioral training is less effective if it's genetic?
That's a good question. No, it doesn't mean training is pointless. It means genetics predicts the likelihood of needing that training.
Ah.
The predisposition suggests maturation might take longer naturally. The training helps accelerate that learning process, forcing the connection sooner rather than just waiting, potentially for years,
Okay, so it helps speed up what might happen eventually anyway.
or what might not happen without intervention for a very long time.
Right. Okay, beyond genes, what else plays a role? Any psychological factors?
Definitely. The guidelines mention psychological stress, things like major family problems, issues at school, even significant trauma like you might see in refugee children, for instance.
How does stress link in?
It seems stress can either trigger the wetting or just make it harder to overcome,
Hmm.
increases tension, maybe lowers the bladder control threshold.
Okay. And physical factors. Anything clinicians should look out for?
Yes, two main things stand out in the guidelines. First, constipation, or obstipation, the more severe form.
Constipation, how does that connect?
It's often present alongside bedwetting. A really full bowel can physically press on the bladder or interfere with nerve signals.
Ah.
So the advice is clear. If constipation is there, treat it alongside the bedwetting. Sometimes clearing the bowel helps the bladder symptoms quite a bit.
Right, makes sense to tackle both. And the other physical link you mentioned was breathing.
Yeah, sleep-disordered breathing, things like sleep apnea.
How on earth does sleep apnea connect to bedwetting?
It's complex, but basically, the disrupted breathing can change pressures in the chest. This can trigger the release of certain hormones, natriuretic peptides,
Okay.
which actually makes the kidneys produce more urine at night.
No way. So treating the apnea could potentially fix the bedwetting.
It's possible, yeah. It highlights why looking at the whole picture, a good assessment is so important. You might uncover something like sleep apnea that needs addressing first.
Which leads us nicely into the treatment strategies, focusing on the non-medication ones first, as the guidelines recommend.
Absolutely. And the absolute foundation, before any gadgets or charts, is education and positive support. It's about rebuilding the child's confidence, taking away the shame.
So what's the core advice for parents to shift that dynamic?
Number one, stop any form of punishment immediately. It's counterproductive, just adds stress.
Makes sense. Focus on the positive.
Entirely. Praise dry nights. And then, a really neat bit of advice, involve the child in an age-appropriate way in changing the wet bed.
Oh, how does that help? Isn't that like a punishment?
Not if framed right. It's not about blame, it's about shared responsibility and management. It takes the focus off, you did wrong, and puts it onto, okay, let's sort this out together. It fosters responsibility.
Well, okay, I see the nuance there. What about the classic advice to restrict drinks in the evening?
Ah, yeah. Surprisingly, the guidelines generally say don't do that. Yeah, unless the child is taking that specific medication, desmopressin, which we'll get to. Otherwise, normal evening drinking is fine.
Why?
Because banning drinks often just creates tension and stress around bedtime, and there's not much proof it actually works for most kids. Remember, the issue isn't usually the amount of urine, it's the brain not waking up to it.
Got it. Okay, let's talk interventions. The guidelines lay out tiers, starting with low-intensity methods. What are those?
Right. Tier 1. These should be tried for at least a couple of months. Two main approaches here. First is lifting, or scheduled waking.
That's just taking the child to the toilet while they're asleep.
Pretty much, yeah. Taking them after they've been asleep for a few hours, often without fully waking them. The standard calls it upnemen.
But wait, if the goal is training the brain to wake itself up, doesn't lifting kind of undermine that? The parent is doing the managing?
You've hit the nail on the head. That's the theoretical objection. Lifting doesn't teach the crucial brain-bladder link. It's passive.
So why do it?
Well, sometimes just achieving dry nights, even passively, can reduce the stress and shame. And for some kids, it might kind of transition into them waking naturally later.
Yeah.
It's not ideal conditioning, but it can lower the immediate burden.
Okay. And the other tier 1 method?
Reward systems.
Yeah.
Simple things like sticker charts, calendars where you mark off dry nights, combined with lots of praise and maybe small rewards for hitting milestones, keeping motivation high.
So tier 1 is about managing symptoms, boosting morale. What if that doesn't cut it?
Then you move to Tier 2, the intensive method. And this is really the core strategy, the alarm system.
The enuresis alarm, or plaswekker as the guidelines call it, this is the gold standard.
Absolutely. It's considered the most effective long-term intervention. It directly tackles the conditioning problem that lifting doesn't.
How does it actually work? The mechanics of it?
It's clever, really. A small sensor, usually in the underwear or a mat on the bed, detects the very first drops of urine. That immediately triggers a loud alarm. The sound is designed to be jarring enough to wake the child up.
And the idea is?
Repetition. Over time, the brain starts to associate the sensation of the bladder getting full with the unpleasant alarm that's about to go off. So eventually, the child starts waking up before the alarm, right when their bladder is full.
Ah, classic conditioning.
Exactly that. It trains the brain to recognize and respond to the signal correctly.
Sounds effective, but I imagine it requires serious commitment. How long are we talking?
It takes time and persistence. The guidelines say you need to stick with it for a minimum of 4 months for the best chance of success, though often you see results starting around 2 months.
4 months of middle-of-the-night alarms. That's tough on the whole family.
It really is. The child has to be motivated, and the parents have to be fully on board to support them through it. It's disruptive, no doubt.
Is it worth jumping straight to the alarm if Tier 1 seems unlikely to work?
The consensus seems to be, yeah, if the low-intensity stuff isn't making headway fairly quickly, moving to the alarm is probably wise. Why prolong the issue if this is the most effective tool?
Makes sense. And if even the alarm doesn't work, then we're into specialist territory.
Pretty much. Tier 3 involves complex methods, usually handled by specialists. This includes things like dry bed training.
What's that?
It's a really intensive program, often over several days, combining the alarm with other specific behavioral techniques. And then there's bladder training.
And who needs that?
That's more for kids who also have daytime issues, like peeing very frequently, say, more than 8 times a day. The training involves exercises to practice holding urine longer, trying to increase the bladder's functional capacity.
Okay, so behavioral training, especially the alarm, is clearly the main path for a lasting cure. Where does medication fit into this picture then?
In a very small, very specific corner.
Ah.
The guidelines are really emphatic about this. Medication is not recommended as the main everyday treatment, not as monotherapy.
Why not? If it stops the wetting.
Because the effect is almost always temporary. It works while you take it, but as soon as you stop the drug, the bedwetting usually comes right back.
It doesn't fix the underlying issue.
Exactly. It doesn't train the brain. It just masks the symptom, usually by reducing urine production overnight. The relapse rate after stopping is incredibly high.
So when would you consider using it?
Only for specific, short-term situations where staying dry is really important socially. The classic examples are things like a school camp or a sleepover at a friend's house.
A temporary fix for a specific event?
Precisely. The main drug used here is desmopressin.
Right, you mentioned that earlier. How does it work?
It's basically a synthetic version of ADH, the antidiuretic hormone our body naturally produces. It tells the kidneys to make less urine overnight.
So less urine, less chance of an accident.
Yep. Works pretty quickly, often the first night.
Yeah.
But again, stop the pill, the effect stops.
Now, you hinted at a safety issue with desmopressin.
Yes, and this is absolutely crucial. Life-threatening if ignored.
Okay.
Because the drug stops the kidneys from getting rid of water effectively, the patient must restrict fluids.
How strictly?
Very strictly. No significant fluid intake, and that includes alcohol for older teens or adults from 1 hour before taking the tablet until 8 hours after.
Wow, 8 hours. What happens if they don't restrict fluids?
They risk water intoxication. The body retains too much water, diluting sodium levels. This can cause severe headache, confusion, seizures. It's incredibly dangerous.
Okay, so that fluid restriction rule is non-negotiable.
Absolutely critical safety point.
And what about other drugs? I seem to remember older antidepressants sometimes being used. Tricyclics.
Yeah, TCAs. The guidelines now strongly advise against them.
Why is that?
Similar reasons, really. The effect is temporary, the evidence supporting them isn't very strong anymore, and they come with a much higher risk of side effects compared to desmopressin. Plus, you have to taper off them gradually.
So if a temporary drug solution is needed for that sleepover scenario, desmopressin is the go-to, provided everyone understands the fluid rule.
That's the summary, yes. Behavioral is the cure. Desmopressin is the temporary patch with strict safety rules. #outro.
Okay, let's pull this all together then. We've done a deep dive into the latest standards on bedwetting. Key message. It's more common, lasts longer than many think, And affects adults too.
Right. And the core takeaway for long-term success is absolutely behavioral. Persistent, structured training, with that Enuresis alarm being the most powerful tool to actually teach the brain to wake up.
Medication really only has that very niche role, temporary help for specific social situations, and only with that critical fluids safety warning for desmopressin. It's not the fix.
Definitely not the fix. And thinking back to that psychological impact we discussed, the shame, the limited social life, the hit to self-esteem, it makes you wonder, doesn't it? Given that these behavioral methods are often so successful, how much unnecessary suffering, how much lost confidence and social experience happens simply because kids or adults don't seek help or maybe aren't offered these effective strategies?
That's a powerful thought. The sources do say self-esteem shoots up after successful treatment.
It does. And the solution is often right there.
Right.
Relatively inexpensive, no pills needed.
Just commitment, support, and maybe a noisy little box.
Exactly. Sometimes the most effective solutions are about consistent training, not just reaching for a prescription.